Hi, everybody. My name is David Johnson, and I'm the deputy editor at Stanford Social Innovation Review. It's a magazine based out of Stanford University. We cover the field of social innovation. We've been doing so for over 20 years, and I'm very pleased to be here at this panel, which is the first of the track on health. So Transforming Health Systems is the title of the panel. And I'm pleased to introduce our four participants. Why don't I start from right to left from your perspective? So at the end, we have Ruth Shaber, MD. Ruth is the founder and president of Terra Health Foundation, a philanthropic investment group that uses evidence-informed programs to promote women's well-being and opportunities. She retired in 2012 from her long career as an OB/GYN and senior executive at Kaiser Permanente. She is also the co-founder and board chair of RIA Ventures, a collective of foundations and investors committed to bringing new types of capital to the reproductive health field. She is the co-author of the XX Edge, or the XX Edge, Unlocking Higher Returns and Lower Risk, which serves as the basis for her new initiative, the Diverse Investing Collective, which aims to increase the assets managed by gender diverse and racially diverse teams to 33% by 2033. So next to Ruth, we have Vanessa Roanhorse, Vanessa is a Diné, or Navajo citizen, and she is the co-founder of Roanhorse Consulting, LLC, an indigenous-led social enterprise focused on transforming health and economic systems for future generations. With 7 years of experience at the Delta Institute in Chicago, she led energy efficiency, green infrastructure, and workforce development programs. She is also a co-founder of Native Women Lead and the Rematriating Economies Apprenticeship. She sits on the board of the Pot Liquor Capital, a way to invest in Black and Indigenous farmers, and is a governing board member of the Just Transition Integrated Capital Fund, a fund designed to move endowed assets to BIPOC and working class controlled funds and grassroots projects through non-extractive financing in the form of 0% loans and catalytic grants. Next to Vanessa is Katie Drasser. Katie is an entrepreneurial leader committed to equality and justice, who has launched groundbreaking inclusive programs that address complex global issues with a focus on public health innovation and the role of innovative financing and leadership in systems change. As the CEO of rockhealth.org, she leads a team of experts in health equity, social enterprise, and design to encourage more equitable innovation in digital health. And last, to my left here, is Geetha Tharmaratnam. She is the Chief Impact Investment Officer of the WHO Foundation. She is an investment professional with 19 plus years experience in private equity, impact investing, and venture capital investing, primarily in Africa, Latin America, and Asia. Geetha has expertise in gender lens investing, ESG, and health. She sits on the investment committee of Aleo Capital, a Botswana private equity fund manager. She's also on the board of and chairs the investment committee of Nyala Ventures, a gender lens fund of funds, and is on the board of Okavango Capital Partners, a climate and nature investment firm. Thank you very much for joining us today. So when we met to discuss this panel, which is on transforming health systems, one thing we seem to have broad agreement is that health is not just one track among many other tracks that we're covering at this conference. Health is something more fundamental in impact investing. So maybe you could elaborate on that point about the role of health in the wide spectrum of tracks we're covering at the conference. And if Geetha, if you could start us off, appreciate it.
Thank you. I think COVID kind of showed us how health cuts across absolutely everything. And the WHO itself looks at health as an outcome rather than as a single sector, recognizing the health implications of having good nutrition, the health implications of climate, where the Director General has identified climate change as the single greatest threat to human health. And so on one hand, there's such a incentive to consider how health is a part of everything, but I think there's also value to separating it out so we can have a deeper, richer discussion about this, knowing that there's interconnectedness, but that we are able to bring a level of depth to the discourse that we're having.
Thank you. Katie, how about yourself?
+1. Every other sector benefits when we are healthy. So every other track has parts of it that matter to health and vice versa. I'd actually be curious in this room, who feels like their work is squarely focused, or like mostly squarely focused on health? And then who feels like they're sort of a tourist in this room, like wanting to learn about health, don't work directly in health? And then who's kind of blended all over? Health is a piece of what they do. When you look across the tracks, so it's a bit of a mix. We do have more health folks here than not. Like, I really hope the AI folks come to the session on Wednesday that Shweta from Google, she's talking about AlphaFold 3, a protein data bank that's a public good for all of us to use. One of the ways it's being used in health is by getting at the root causes of rare diseases. Or neglected diseases that have taken years and billions of dollars, and they could do it like really quickly. That is going to sit in the health track, but there's an AI track. I hope some of those folks come over and vice versa. Or education. I work at Rock Health. We've, since 2011, been tracking venture funding. Venture is 0.5% of funding in business financing, just to be clear of the perspective. And in healthcare, it's just a small piece of investing in health. But it represents some of the most innovative, some of the most disruptive in a good way, not like, we don't want to too disruptive in healthcare is a little bit of a funny thing. But we've been tracking that, and when you look at, for instance, 44% of digital health startups that serve youth contract as part of their business model with schools. 17% of schools offer telehealth for mental and physical health. So actually, education is a huge part, among like a million other things. Those are like two stats. A huge part of health and vice versa. And so I hope that some of the education, I hope we travel between tracks and kind of bring some of the stuff from today into other tracks and vice versa. It's not really an answer to your question, but mostly to underscore the point that, like, we did have a little argument about, like, oh God, do we really want to be our own track? But to your point, there are some actual very specific things in healthcare that we need to kind of like roll up our sleeves on, and hopefully we can do together on the track.
Vanessa?
Sure. Hi, everybody. Ate. So my work sits at the crux between health and wealth. We have found ourselves designing all kinds of capital products or programs, but the reason I think when we started this conversation that I felt was so critical to share is that from my perspective, all of this money moving is a Western way of understanding success, when really why we move all this money is so we can have a dignified life where we want to live, to eat the foods we desire that caretake for us, and that we get access to the tools and medicines that ensure that we are here taking care of ourselves, our community, and the land around us. It's not, the purpose for me isn't capital wealth. The purpose is, how do I ensure capital moves so that we are healthy to have freedom, liberation, agency, and sovereignty to do the things we want to do? And so this track, in my mind, was like, we should be just talking about all the wealth from a health perspective. Because if we did that, we would have a direct relationship with the land and the people around us and the other living beings, because we would be connected and tied, not the other way. Because if at the end of the day, if the return on the investment continues to be to the return on our investors, not the return on the impact to the earth that we're living on, we'll continue to be having the same conversation. So I'm hopeful that as we talk about this track and why it matters, that we do see the cross-pollination, because this should not be a siloed track. This should be the undergird for why we talk about wealth.
Ruth?
Yeah, so well said, and I certainly agree with all the wisdom on the panel here. I would add one other dimension to it, that we think of our work in order to improve health and improve quality of life, improve resources. But if we don't have health, then in all of the other things we care about, sustainability, climate change, it's in some ways all of the other things we want to see are luxuries that aren't available to us if we're not healthy. And as a physician, I certainly see that in a family. If there's a member of the family that's ill and it's draining all the resources, and certainly in communities and countries and the planet, if we can't optimize health, then none of the other things that we want to obtain are going to happen. I think Christiana said it so beautifully this morning too, that it's not just physical health, but it's mental health, it's spiritual health, and we need that as a platform in order to achieve all of our other goals.
Thank you. Vanessa brought up return on investment, and obviously a lot of impact investors are thinking about return on investment. How should they think about return on investment investing in health systems, given the importance of health and how fundamental it is to quality of life? Ruth, do you want to go on that first?
Well, in how I think about it and the work that we're doing at RIA Ventures, it's all about health equity and trying to close some of the gaps in health outcomes that are so prevalent around the world, but certainly even just in the United States, even within communities. And how do you actually, as an investor, how do you look at a company or look at an opportunity with a health equity lens? What does that mean? It means things like looking at access. Will all communities, will all individuals have access to this technology? Or cost, who's going to pay for it? Is it just a luxury good, or is it something that will be reimbursable by the government or by insurance companies? What's the price point? Or geographic equity? Or what are the HR policies in the company that you're investing in? What are their representation within the company? Or who's actually designing the product that the company's making? So there's a whole matrix of opportunities to evaluate an investment opportunity with an equity lens in order to get all the things that we're talking about in terms of healthy communities. So that's my approach. That's how I think about it.
Vanessa, how about yourself?
So we center our Indigenous worldview as part of our methodology and the way we approach research and the way we ask questions. And so for me, when I think about impact investors wanting to support communities like mine, who, we talked about the pandemic earlier, like when the pandemic happened, if you were from tribal lands, or for me, grew up on the Navajo Nation, I didn't have running water until I was 8. This is the United States in Arizona. When the pandemic happened and showcased the lack of just basic human rights and infrastructure, the fact that my own neighbors, because I live in Albuquerque, New Mexico, were surprised continues to remind me that when we talk about impact investing and the purpose and the return on the investment, I think so much of the question has to be like, well, what are the things we don't have to get us to where we're trying to go? Who gets to make those choices? And your return on the investment, if you have the ability to have that kind of capital, to ask for an ROI, we should be really asking ourselves why we're not just getting it and putting it into the hands of the people who are doing and living in those places this work without question. And if we could just even start there, then maybe we can start talking about how many trillions this morning did the folks did Anthony Bug Levine talk about? It's not that hard. And I think that's what's so frustrating about impact investing is it doesn't have to be this hard. But it is, because we keep confusing return on investment from either a market lens or return on investment in which the investors are taken care of first versus the land we're living on and the people who are most harmed.
It's almost like we can't seem to hold both very well. For those of you who were at SOCAP in 08, we said that then too. Yes, it is. We're making it a little hard for ourselves. You want me to? I'm not often the capitalist in a room. I'm like a public health gal. Deloitte came out with a report last week, the week before, $2.8 trillion would be added to the US GDP by 2040 if everyone had better access, equitable access to good health. Corporate profits would soar above 700, is that a B or no? Let me look. $763 billion in increase in corporate profits if we had equitable health outcomes in this country. And so when I think about how we struggle to hold both, like, could we just? I think we have made the business case for health. We were chatting earlier. I think we wildly underestimate the ROI in health. I think we do not do ourselves a service by kind of, oh, it's this much, it's this. No, it is like everywhere. The ROI is so gigantic to the planet, to the people, but to the money. There's a lot of money. It is the largest sector in the US. Like, it is not a lack of, people are making a lot of money in healthcare. This is not a lack of money, it's a lack of imagination and a lack of a definition around innovation. At Rock Health, we often say it is not all that innovative if it's not equitable. That's lazy innovation. Get better, do better. It's not innovative unless equity is centered in the innovation. It's actually really hard to do, but not that hard. We travel mostly at Rock Health in this space of tech and healthcare coming together. By the way, another gajillion-dollar industry in this country, and I bring a really U.S. lens. I know, Geetha, you bring a more global lens, thank God. But you asked about access, like what actually increases access. Well, guess what? Like, we're low on healthcare workers. We're looking at technology. If technology is not a part of the plan, what is the plan in this country? So tech, I think, again, I'm not often the tech person. I'm a public health equity person. But if tech is not part of the plan, what is the plan? And we see with technology and looking at ROI, when you look at some of the innovators building these companies, they're native-led, they're women-led, they're Black, they're people who bring lived experience, they're people who have the very thing they're trying to solve. No entrepreneur is more motivated than someone who has been impacted by the system. You want grit, you want commitment, and you look at those startups and those entrepreneurs, and you look at some of what they're innovating. I'm not talking about every digital health startup, but for some of them, they're building from that place, and then you look at our database across the US. Who's using telehealth? Do you know the highest and fastest adopters of digital health in the US are Black folks? The same survey told us from the Rock Health Consumer Adoption Report, they're also the least satisfied. That's a business opportunity and a moral imperative and an opportunity for better innovation, and that's just one data point. Trans folks, LGBTQ folks are really drawn to technical innovations in healthcare because it's reaching them and serving them, and yet, oh God, there's so much more to do. Please don't take this point as, oh, we're done and we're reaching everyone. We're not, but there's so much early promise that we can, and we already are in many ways. And so when I look at the ROI, how do we get more funding to some of those innovators? How do we partner with local institutions? Those partnerships take some money. Like, how do we, all of that requires more money to do it, among other things. But I'm tired of the excuses of not enough money going into these spaces. Go ahead.
Let me try and build on what you're saying here. When we talk about ROI, we talk about return on investment, but I think we also need to be talking about return on impact. And I want to just broaden this out a little bit outside of the US as well, and just by way of context. So I was born in a hospital in Blantyre, Malawi. Botswana is home for me. I grew up in a town of less than 100,000 people, in a country that is the size of France, middle-income country, in a country that now has 2.5 million people, and is blessed in very many ways. But then I now live in London, in the United Kingdom, which has universal health coverage, which is falling apart at the seams. So there's quite a wide breadth here that I'm going to cover for a moment. I think there's two things I'd want to focus on. The first of which is one of the things I find most frustrating about impact investing, and I hear you, Katie, when you say you're not usually the capitalist in the room, because very often I find myself the capitalist in a room where folks are very socially oriented, and then I find myself the socialist in the room where people are very capitalistically oriented. And I think this is a point that you brought up actually earlier, Vanessa. If we're using a broken system to come up with a new way of doing things, why are we relying on that broken system? SOCAP is, and the topic this year is about systems change, yet we're still talking about risk, return, and impact. We're using the same broken system. So what fundamentally needs to change? And that's something where I think that we really need to push hard, because they are investors who we need to find who are willing and interested to back different approaches. Because there are fund managers out there, Ola, you're sitting here, who are raising funds, doing things in a very different way, but still having to speak the story of returns, impact, risk. You add geography in there, you add sector, you add currency mixes, and it just becomes riskier and riskier and riskier. I had a conversation with somebody who's leading the impact investing team at a foundation outside. And he said, Geetha, what do we have to do differently? Because the capital is going into the same investors, because we've had great investors who have done a lot, commercially speaking, now move into the impact investing space, and they set up mega funds. It is easier. It is, you're not going to get fired for investing in a investment firm which has a huge track record and has happened to just set up a multi-billion-dollar impact fund, right? But is that where the greatest amount of innovation is happening? Maybe, maybe not. So how do you seed other initiatives as well? And this, for me, is where, when we think about how you're assessing the performance of limited partners, whoever they may be, foundations, family offices, philanthropists, pension funds, whoever it is, I think there's a wider scorecard to start using with them as well. Which is to say, okay, when you're looking at returns, how you're achieving those returns really matters. We've looked at it from a gender perspective when we talk about gender lens investing, right? We're looking at it from a few other perspectives. But I think we need to think also about how you're changing the system through which capital is being deployed. And there's an example I would like to leave with you. Last year, I had the privilege of sitting on the oversight group of a very interesting initiative. The Church of England has an investment arm. It is managing roughly about 11 billion pounds, which it is investing as a sustainable investor for financial returns, and that goes to support the pensions of priests. It goes to support parishes which can't afford to fully run themselves. And 3 years ago, they faced up to a reality of their past, which is that they had directly invested in the transatlantic continental slave trade. Directly invested in that and received funding from that. So they apologized and made an allocation of 100 million pounds to go into impact investing. And then put a group of 14 of us to come up with a strategy for that. One of which was even naming this thing. So we had a few of us who were investors on there. We had activists, we had journalists, and we had theologians. We had 2 bishops on there as well. And the starting point was, this is part of an original sin that was created. So even if you come up with an impact investment solution, there are some things here that need to be addressed. So the name of the vehicle, what we named it, is the Fund for Healing, Justice, and Repair. And we said not 100% of the capital is going to go into impact investing, because a portion of it has to go into the continued documentation of the reality of what happened. A portion of it has to go into healing and justice, so that there is a systemic shift in the way in which capital is being deployed, but neither are you throwing money into a situation and saying, I need that to succeed at all costs, and not recognize the damage that's been done. I offer that as a bit of an analogy to where I think there's room for us to grow as impact investors, especially within the health space. And there's so much urgency because there's so much unmet need. We know this. And COVID left us even further behind, right? It left all our countries further behind. And so there are many of us who can sit there going, we need to scale. Access is about scale, scaling is about getting to as many people as quickly as possible. But you've heard everyone here talk about health equity. If we do not take that step towards moving towards health equity, we will scale that which is really not sustainable. And we will find ourselves in the same deep hole again and again and again. And this is where I think there's really an opportunity for us to think about return on investments and return on impact in a different way.
Thanks. So I'd like to follow up on that and ask you about your work in transforming health systems. You all work on different points of focus in different parts of the world. So tell us either about some successes you've been seeing or challenges you're seeing in the field in which you work. So Ruth, maybe you can start us on that.
Well, I will give a caveat that this is a story that we haven't gotten to the end of the story yet. It seems to be going well. And also to recognize that the story involves a relatively conventional form of capital, but I want to also acknowledge that this is not shouldn't be the only form of capital. But in my career in medicine as an OBGYN, I couldn't help but notice that over my 30-year career, we were using exactly the same technology for contraception as in the beginning of my career as at the end, that essentially there was no new science. Some pharma companies would come up with new delivery systems, but there was no evolution, no investment. And in 2018, the time that I was starting on our investment strategy at Tara Health Foundation, it was clear that the amount of capital that flowed in for research and development in contraception was about 1/100th of what went to oncology, for instance. And yet, contraception not only impacts every individual and every family and every community, it's at the core of so many of the other social impact improvements that we want to see, whether it's climate, poverty alleviation, urban development, whatever it is. And so here was such an essential social technology that had no science to back it up. So when we started to roll up our sleeves and try to understand why only 1% of venture capital goes to women's health technology, for instance, it's obviously all about the money and who's allocating the money, who's making the decisions about where the money goes. In 2018, there was only one new contraceptive technology that came to market. There were 19 new oncology technologies. So what we did at Tara Health Foundation is we used our grant money, so we used our philanthropic capital to help build the infrastructure to bring in other, both philanthropic donors, but also other investors into a pipeline of companies. And it was I'm happy to say it seems to be a virtuous circle, that as we launched RIA Ventures and RH Capital, and built this engine to help bring in other LPs, the pipeline seemed to be growing. And even though this has been a slow time for venture capital in general, since 2018, we've seen a growth in women's health investing that's about 300% compared to the growth in more conventional med tech of, I think it's more like 10%. And a lot more attention to women's health. And I'm also really happy to say that RIA Ventures is now among other women's health focused funds that are seeing more capital flow and more pipeline. So it's definitely an opportunity of recognizing the huge gap in the market, that it didn't make sense that there was such a gap. I mean, we know why. And we know what the social and political pressures are on investing in women's health for sure. We don't even need to go there today. But
oh no, we can go there. I mean, somebody said it's the elephant in the room.
It's such a great example of the artificiality of the markets, where there's extraneous forces that keep male venture capitalists traditionally from thinking that, well, hey, maybe women's health is actually a good market opportunity, or that, gee, just because I might not be using contraceptive technologies today that maybe the rest of the world needs them. So there's this leap of being able to translate why the market is a great place for this kind of research and development. So that's my story for today.
Who would like to jump in next? Vanessa?
I don't want to just talk about the challenges, but it makes me think a lot about like, when I think about the kind of health work that's being done in the United States, we call it Indian country, on indigenous lands, for indigenous people, by indigenous people. My first part around this is what I have seen is companies come and they develop something and it's working for the community that they're serving. To grow it, to get the kind of money they need to grow it, they don't have the right relationships and networks to activate that next level of capital. So historically, as indigenous people, I think in Bay Street shared that in 2021, 0.004% of VC went to Native indigenous people in the United States. Venture capital is not a pathway for a lot of our solutions that are working and that are happening and that are solving huge things. So that means we have an entire asset class that just disappears for us completely. And then we're left with predatory lending or traditional bank lenders that if you're building a solution on tribal lands, you actually don't have the privilege off tribal lands to own the land you live on as an asset, to have collateral, to have something to go to the banks to get money with. So you can't meet the underwriting requirements. And it's very frustrating. And then if you make a very successful solution, because of the size of our population, there's not enough scale. And the solutions have to be place-based. So you add that into this like investment strategy around health equity and health opportunity. Indigenous people in the United States aren't at the table. We're not building solutions at the kind of scale and return that folks want. Venture capital isn't going to solve our problems, and it's not going to solve most of our problems in this world. And then the last is those that are building problems, like Jordana Saunders right here in front of me, Trauma Health of Arizona, Recovery Services. What's happening is they are on their own to find capital. And because we don't have the kind of wealth where we can access friends and family rounds, where do you go? On the other side, what I have seen successful and something we've been doing at my company for the last 10 years is working with institutions that have infrastructure to move capital, to provide the runway to community-led partners on the ground, to not have to go through the process of being a fund manager or have to deal with regulations, but to help those leverage credit unions and banks to provide low interest, patient, and equitable capital led and designed by the people where they live. Character-based lending is not new, and the kind of innovations that debt can do is really something I think we need to be exploring more, and I really want impact investors to start looking a lot differently at that kind of capital. We need catalytic capital that allows us the kind of ability to provide 3%, 5% loans, but also we need grant funding that comes alongside this. None of this is new. None of the things I'm talking about is innovative. This stuff has been around. The difference is who gets to decide who underwrites it, who gets to decide what the criteria and due diligence are, and then lastly, we make a different relationship with this idea of scale and growth. So for me, the opportunity here is like, how do we reclaim language like impact, risk, and interest, and actually ask ourselves what's really working on the ground and how do we just double down on that investment? Because the tools that we're working with today are not the tools that are going to get us into the future, but that they're tools that are going to help us understand how to build a future.
Why do I keep going after you? I could listen to you all day. you're making me think about a lot of things. I could prepare remarks and be all ready. But when I listen to what you're saying, it's like, what is actually going to transform healthcare? I think we've been asking this a long time. We have, again, I'm bringing a US-based lens. Our system is broken, as we all know. I think I travel in a lot of health equity spaces, and the thing I long for are some narrative shifts around solutions. I feel like we're really burdened in health equity spaces by all that's not working. For good reason, we're burdened by that. And many of us are like actually affected by the very thing we're working on. And yet, there's a lot that is working. Or when you look at, I sit in a lot of rooms recently around AI, and is it transforming healthcare? And all the health equity leaders will tell you about all the problems, but actually, we could use it to advance health equity if we flip it a little, and it's already being done. There's some narratives in AI right now around taking jobs and, you know, building off bad data. Guess what? We're already building off bad data, by the way. We're like already doing that, so we already did that. We invested in a company called Marigold Health. It's a substance use peer support system, company to help folks who are struggling. The peer support counselors are paid, so it's a form of a job. I don't know if it pays all the bills. I'll get back to you on that. But it pays, and their success rate is very early days for them. But their success rate is 98% of the 2,000 people they're serving. Because you want to know what? If you want to grab a drink or do the thing that's kind of keeping you down, the person you might trust the most is someone who's been there too. And so there is AI supporting the conversation, the interaction, so that an everyday layperson who's been there can have some guardrails, some flags, some resources to help guide them in their peer support. I think that's cool. I'd like to see more of that. I mentioned AlphaFold 3 earlier, getting at the root causes of neglected and rare diseases that would otherwise take us 100 years to figure out. What if we could do that in the next year for some? Most people don't even know about this protein data bank, by the way. Most people I talk to don't even know it exists and is free to use. Again, go to Shweta's thing on Wednesday. So I see a lot of these innovations. Do you know that every woman in this country and around the world, if we're lucky enough to get older, will hit menopause? Guess like how much innovation starting 3 years ago, like was not happening in that space. I'm excited by that. Do you see what's happening the last few years? There are some amazing companies and innovations coming to bear in that space that has just been like totally ignored and not even talked about, mostly for what you said, Ruth, because who the heck was making all these decisions anyway? And I know the money's not going to solve everything, but if you've ever tried to raise a dollar, like $30 billion went into digital health in the US in 2021, and we're looking at about $10 billion a year ever since. That's not nothing. With the right people like you two, like half the people I know in this room, if you had that money, that makes me hopeful. And it's not nothing. And so we pay attention to it, recognizing it's just the money part of it. But like, let's get some of that money to people like you and to many, many others.
We want the money.
Who actually center equity in their innovation. And that's what makes me hopeful. That's where I see the seeds of transformation happening.
So I'm going to try and be complimentary to what you've all added here. And one of the things I want to bring up is how are we defining success? Mm-hmm. And what are we investing in? So where is the innovation taking place? We talked a bit earlier in this conversation about the innovation taking place at the capital allocation piece of it. But the next piece is the entrepreneurship itself, and then the mechanisms that are allowing these businesses and these organizations to reach communities who are using these products and these services. And that context, I think, is really important. So much of, I try to not lose the connection of the work I do relative to the life I have lived and continue to live, right? So I will tell you, I had my first mammogram 2 months ago. I'd never had a mammogram before, and it was bloody painful. Genuinely, really, really painful. And the name on the machine was Siemens. And I was thinking, the next time I see the Siemens impact investing head, I'm going to have a conversation about this. But it also made me think about the business that we came across last year that has been developed out in the Middle East, which is a handheld mammogram, which allows you to actually get a mammogram earlier. And this was created within a community which recognized that women in that community were getting breast cancer at roughly the same levels as women elsewhere, but 10 years earlier, which meant that they needed access to mammograms which could be used on younger women. So, to your point, Katie, sometimes you will see, often you will see that the innovation is driven as a result of the requirements of people who are living through this. A handheld mammogram. And when I met that company, they said, let us come into your offices in Geneva and give every woman in your office a mammogram. And you will see, number one, it's not painful. Number two, the false negative rate is much lower than what you're going to find elsewhere. So this actually makes a difference on women whose skin is darker than what you would otherwise expect with the current machinery that has been developed. Now the question is, who finances that business? And what they told me is, we want to take it into the US, and that's where we think we're going to make money, but we want to give this away everywhere else in the world. So the question that they had is, how can we get this into hospitals, into clinics, into community healthcare centers globally, recognizing that this is a business that needs to make money in order to continue to grow and thrive and innovate, etc. But is there a model which allows it to be used philanthropically as well? And so when I think about something like that, from a financing perspective, I think about blending. How do you bring capital from different types of funders? And I say funders rather than investors, because you'll have certain investors who want a certain return. You'll have some who want a lower return. You'll have a type of funder who's saying, actually, I want to take a lot of risk, and I don't want to take a return, or I can't take a return. So how do we use blending more at scale within these circumstances? And it's easier to have that conversation when you're talking about a large sum of money being used for a large project than one individual company, which is sitting in the Middle East, which has come up with a very interesting handheld mammogram machine. So when we talk about what we're doing in this space, I want to just mention a little bit about what we're doing at the WHO Foundation. So the WHO Foundation is a private Swiss foundation that sits alongside the World Health Organization. The WHO, which is a part of the UN, and which is, really there to protect the rights of all of us, including in the US, including in Europe, to have equitable health care. It is for all of us. And one of the things that we thought about very early on when we set up the foundation was, how do we work from an investment perspective? So we developed a mandate for a fund, the Global Health Equity Fund, and we identified a fund manager who is highly experienced from a VC perspective, but who comes with a great deal of health expertise to say, what is it that we can do that can be piloted here and then replicated again? So the first thing is, this is something which is looking at low and middle income communities as opposed to low and middle income countries. It is also recognizing that for a startup to be truly successful, you can't be pushing it into low and middle income communities only, because that business has to get enough funding to survive and to carry on innovating and to be able to grow. So there is this balance here of making sure that these businesses are able to grow, but what are the different types of funding, and here is where the blending comes in, that can be brought in to support these organizations. Here's the next thing. All healthcare is impact. Yes. Would you agree with that, or would you not agree with that?
Or don't call yourself it if you're not.
But here's the thing, Katie. If you have incentives, you will be a lot more impactful. And so this is where we said, okay, what we're going to require is that any company that gets funding from this fund has to sign the health investment access, the health access pledge. And that's saying that we are going to, and it's embedded into the legal documents, which says that they are going to make their products, their services their technologies, and their data analytics more available in low and middle income settings. And the assessment is done all through the investment life cycle. So you have to find ways to weave in incentives and obligations, put it into the legal agreements, and then embed that in the investment life cycle. So there's a degree of accountability that is diffused throughout the whole process. Because otherwise what you're counting on is that everything you do in healthcare is impactful, but you're missing the opportunity to dial this up and have real intentionality behind this. Because remember, even with the impact operating principles that have been developed, led by the IFC, adopted by the GIN, the heart of the point of impact investing is you must have intentionality and demonstrate that you are actively trying to add value, as opposed to getting really good at telling good stories around what is being done. And that intentionality for me is taking the laziness, I think you use this word here, Katie, you take the laziness out of investing and say it's not just about finding a great business, which you think is going to be having a lot of impact, it's remembering that you are on a journey, a multi-year journey in most cases, and portfolio management is the single most important thing you can do as an investor with those companies. And here's the thing, that's what the entrepreneurs are looking for. So for me, the ways in which you can really drive some change here, because as you'll see a theme here with me, David, in terms of I think there are ways in which we need to be less lazy as investors, and we need to be more aligned with the long-term development of these businesses, these enterprises, which is actually what entrepreneurs are looking for, and keep our eye on the ball in terms of saying this is the intentionality around the outcomes we're seeking, the impact that we're looking to have on these individuals, these communities, and you need to have a degree of reporting around that to see whether it's actually happening.
Thank you. Well, we're right now about to have time for Q&A, and I think there are pieces of paper and pencils in the back where you can write down your question. And as you have the opportunity to ask questions, I wanted to ask one more of the panel. You say there's a lot of money to be made in health and health investing, but there are a lot of people making money off of illness. A lot of people making money from illness-inducing behaviors, whether we're talking about social media and how it affects teenagers like my 13-year-old daughter, or processed food and the horrid amount of illnesses that can cause. Speaking as an American, I'm familiar with both these aspects. So how do you address that problem in our health systems, that there's a lot of money being made on illness-promoting behaviors and illness in general?
Well, I'm not going to directly answer that question. I'm going to take a somewhat broader lens to it, because I was taken by something that Geetha said about all healthcare has impact, and it's actually, I think, a little more complicated than that. And of course it is, you know that there is a lot of healthcare that is generated, especially in developed countries like the U.S., that has actually either it's because it's draining resources that should be spent on some other technology, like the examples that I gave, but also that have collateral damage associated with them. So I think we have to be discerning and not just assume that any healthcare innovation is going to have benefit. A lot of them have maybe a small incremental benefit, where there's other uses of our resources that could have much, much larger transformative benefits. So I just wanted to add that to your statements, Geetha, which I really, really think are great. You know, some of the impact of technologies and whether it's social media or processed foods or so many of the other things that create, that behaviorally create harm. I think that there's many different approaches. As a public health person and a provider myself, I know that there's opportunity for policy, something that we don't talk about enough in these sorts of forums. I think that we all are much more excited about our investing or our philanthropy, but influencing policy is essential as well. And there are just educational opportunities as well, and awareness building. I'd say those would be my suggestions.
anyone else? Go ahead.
Has anyone here eaten Nutella? Have any of you seen that image of a Nutella bottle which shows how much of it is sugar? You know, sometimes just knowing is helpful, right? Just knowing is helpful. But I think for me, the biggest thing is preventative care. And this is one of the hardest things to finance. We leave it in the hands of our government. Sometimes you have insurance companies who are doing some preventative work because it reduces the incidence of claims. But one of the best things we can do is actually finance preventative care. And historically, we've just found it very difficult to do that. So there's an element of this as when I think about the funds that I've worked on, we try to bring parts of that into the primary care that is practiced in the hospitals that we've invested in. But honestly, I think if we can figure out ways in which we can properly finance preventative care, that's how we're going to have a shot at trying to get closer to value-based care. Because as long as we have the kind of delta between the quantum of need versus the availability of resources to serve those needs, we just are never going to close that gap. Though technology is going to be a big part of helping, but I don't think we're going to close that until we can find an answer on how we're going to finance and embed preventative care to make it a normal part of how we're living.
So I have a lot of great questions here. I'm not sure we're going to get to all of them, but our panelists will be here after the Q&A too, if you want to ask in person. So one person asks, I work at an innovation research institute that focuses on integrative health. We're in Arkansas, which experiences the worst maternal health outcomes in the nation. Can the panel share thoughts on place-based approaches to population health in emerging ecosystems, philanthropy, VC, et cetera? Ruth, you want to?
Well, I know that we all have opportunities to comment on this, but just quickly, I think that community-based healthcare workers is something that in Arkansas could learn from programs from around the world. That when you bring, whether it's peer coaching or health educators or doulas or midwives who are from the community who have the cultural competency to address the needs of the patients in that community, that's been shown to have more of an improvement in outcome than just about anything else.
Yeah, I am in agreement. A lot of the work we've designed really has to hearken. We see a lot of the solutions globally. I think a lot about the promotorial healthcare model, where you find healthcare workers from the neighbors and the people who live there, and then you educate, and they educate you. You provide them information, and suddenly you have human-like folks from where you're from who understand, because they have the lived experience that you have, what you're going through, and can help direct. But I would want to take it even a step further in terms of like emerging ecosystems around providing more integrated healthcare, which is we have to acknowledge that these communities who have maybe not had technology and innovations happen for a while for a lot of reasons, have created solutions themselves, and for indigenous people ancestrally have these solutions. So how do we also get into a mindset that Western academic solutions are the only viable solutions towards integrated health? When you have access to safety, to land, your spirituality, your community, and to the foods that treat your body good, you will naturally respond better to everything else. When you can be in your community and have a ceremony or a healing or something like that, you heal better over time with these academic Western healthcare solutions. I think we forget, because we call them emerging communities, emerging ecosystems, that we forget that like they're still here. They've figured out something. And the solutions we bring, we should center their solutions first and understand how to build around it. This idea, I think, with healthcare, too often we are not acknowledging that these solutions, these healthcare solutions and these ideas of health have always been here. And it's very telling when we talk about how they get funded and invested in, because we get stuck in the language of new innovation and even the language of technology, when sometimes just access to your own language can be more than enough. And like for me, a really nice bowl of like mutton stew, you know, like that is a healing property for me. So I just think about reframing who has the solutions and who should be leading them is really critical, especially when we talk about health.
Two questions here that are related, so I'm going to ask both of them. One person asks, going beyond health, what are your views on investing in the social determinants of health? And then another person asks, increasingly and in multiple academic disciplines, we recognize the tight and positive relationships between nature engagement and human physical, mental, and social health. How are impact investors being included in providing more people with engagement with nature, both real nature and virtual nature? So do you have views on either social determinants of health or nature?
I'm happy to start with social determinants of health. So the fund that I had mentioned earlier that we had set up, 30% of it, so 70% is focused on medtech and health tech, 30% are determinants of health outcomes, specifically focused on climate and nutrition. But there needs to be a very clear line of sight to what the health outcomes are expected from that, right? So I think we need to increasingly not just talk about this, but actually recognize this in the investment strategies. That's a critical part of this. And the other thing is, again, to be careful about assuming that everything comes to a health outcome without saying there's intentionality around what it is we're trying to achieve and how is it that we are trying to dial that up to be more impactful.
I'm a huge SDOH fan, and not one person ever was like, I'm working on my SDOH. You don't sit in a community and come up with a solution, go like, I want to work on my social determinants of health. It's not the language that is used. It kind of goes back to the place-based thing. If we actually center in place and we center what people want, what they need, I actually think and actually really listen to folks, I actually think we are on a path to starting to address the SDOH. We often just do this. We like create the solution and which is why I'm optimistic about some of the innovators I mentioned earlier who are coming from certain communities and building solutions that actually work best there and then grow them from there. I think about kids in the US a lot these days. We just came out with a report on the opportunities to invest in youth mental health. I'm going to build off another question you had. I don't know if this is related to nature, but I'm pretty sure it's good for your mental health. I'll leave the nature question to someone else. But in terms of SDOH, if you look at kids and what's making them sick, especially from a mental health standpoint, there's so many inputs that could be helpful. But I'm super encouraged by the ecosystem that sits around kids and how prime it is for innovation, how prime it is for funding. When you take that SDOH, when you look at the employers to the parents of these kids, when you look at kids' food, when you look at the schools kids are in, et cetera. Millennials are parents right now. 98% of them are talking to their kids about youth mental health. That's encouraging to me. And when you look at some of the innovations that are happening, going back to SDOH and listening to people, almost all of the digital health startups for youth mental health, by the way, mental health is $1 billion a year. It's the largest category of funding. That's what the demand is. That is where innovation is happening. Almost half of that is going to youth. Those startups, almost every one of them has a panel of youth that is informing the design of what they want. Anywhere from, anything related to SDOH, but it's coming from a frame of what they want and what feels healing to them and what feels innovative. I don't know if you want to call that SDOH or not, but I think back to who's designing these things and if we really are listening to people and doing some place-based work and taking into account people's identities, I actually think we get to the SDOH. It's not the only way to get there, but I just often think about
how much no person, that's a frame we put on things that I, again, am obsessed with in my own right. But when we're thinking about designing innovations and what might change, I'm reminded of that. Like, we have to actually listen. In this case, my example of you, we have to listen to the kids, or we have to listen to the community. And I actually think we get there, or have a fighting chance of getting there when we do that. Yeah.
One last question. This person was reacting to something Geetha said. How do you see impact investments working more closely with traditional ODA and philanthropy? In my experience, working with bi or multilateral donors in philanthropy, it's quite siloed. What can impact investors learn from other funders?
Oh, that's interesting. So 15 years ago, I was in a working group at the OECD, and it was a topic I thought was quite random, but I was glad to have worked on this with a group of investors where we were trying to figure out what is needed from an imagine 15 years ago, from an impact investing perspective, for governments that are deploying funding through their Overseas Development Assistance, ODA, which is normally aid, non-return seeking. But how might tax regulations come in to allow them to start investing that and getting a return? And it was such a specific thing, but it went back to the OECD countries and allowed for the treasuries there to start having a discussion about how do their systems look different? How are they accounting for the ODA if some capital is actually coming back, because it's not just aid going one direction? You fast forward now, you have multilateral development banks, which work with a series of instruments, right? All the way from grants, technical assistance facilities, to equity-based solutions, to debt-based solutions, to guarantees. So we've moved a lot further now, and then you have the development finance institutions that sit beneath them. So whether it's BII, the British Development Finance Institution, or here in the US, you have the DFC, which is doing incredible work. Really, I think they're one of the leading development finance institutions that are out there right now in terms of making equity investments through fund managers. They're also doing debt-based solutions. They're providing guarantees. They're doing some very interesting things in terms of outcomes-based financing. So what might impact investors learn? I think the first thing is for those impact investors who are investing in Latin America, in Africa, in Asia, the development finance institutions usually are your first port of call when you're fundraising. So you're already having that conversation. For those of you who are not as familiar, it's actually worth becoming familiar with what these development finance institutions are doing, because they are further ahead than you may think. But I think the biggest opportunity here is for blending. It really is there for blending. And I can give you plenty of statistics around how much this might unlock, but you need to still do the hard work of trying to get lucky to find investors who are willing to come into a blended solution. Because you can define what you think is going to be helpful to address the very specific risks, return, and impact profile of your particular financial solution, whether it is a fund, whether it is a debt product, whatever it is, right? Whether it is an individual company that's raising money. But then you need to get super lucky to find investors, and you knock on 15 doors and you're lucky if you get through one door. So how can we get more targeted about identifying who is doing what? And there's so many funders as well who are fatigued. They're fatigued because the volume of incoming is so great that it's hard to go through everything. And so that's where I think it's helpful for us to be useful to each other and refer on. So if I hear something, or if any of my team members hear something where we know we can't be helpful, we've made a commitment as a team to say there are 3 people we'll introduce you to who we think might be specifically tailored towards what you're looking for. So I think we need to refer more, because otherwise the fatigue just leads us to narrowing our pipeline and making it incumbent on whoever's raising the capital to just keep knocking on doors again and again. And that just means that the timeline to fundraisers is very long. And I personally would really love to see that timeline become shorter, because the kind of lost energy that is spent in fundraising versus actually doing the work, whether you're a fund manager who's trying to make investments, whether you're an entrepreneur who's trying to grow your business, right? And to try and have the impact that you're trying to have. I think that if there's one thing we can do, we've got to try and reduce that fundraising timeline. And I think for that, we really need to know what each other are doing. And again, I'd really encourage you to take a look at what the development finance institutions are doing, because I think there's a great deal they're doing pretty well. I'd just love to see them take more risk.